infectious and inflammatory diseases, and acute complications of head and neck neoplasms. Now, usually acute infections resolve spontaneously or with treatment from the primary care provider, and they don't warrant imaging. It's when complications happen that imaging is done. And although complications can happen in otherwise healthy patients, there is an increased risk of complications in older patients, those with diabetes, and those that are immune compromised. CT is the primary imaging modality, but MR is more accurate for intracranial complications and spine infections. The radiologist should pay particular attention to airway patency, vascular complications such as thrombosis, pseudoaneurysms, and hemorrhage, and spread of disease to the mediastinum, the spine, or intracranial compartments. So I'll be going over these conditions according to the primary location of involvement, always remembering that there is considerable overlap and the condition involves more than one space. So we're going to start with the oral cavity and the pharynx. And the first patient in the ER today is a 35-year-old with facial pain and swelling. A CT neck with contrast was obtained, and this is an axial image at the level of the maxillary sinuses. You can see the acute inflammatory changes in the right cheek, reticulation of subcutaneous fat, overlying skin thickening. There is a rim-enhancing fluid collection along the anterior margin of the right maxillary alveolar ridge with surrounding inflammatory changes. The coronal image is also showing that rim-enhancing fluid collection along that right maxillary alveolar ridge consistent with an abscess. And on the bone windows, you can see the subtle periapical lucency surrounding the root of what appears to be a right maxillary canine tooth. And there is a focal cortical dehiscence along its buccal margin. So this is an odontogenic abscess arising from a carious right maxillary canine tooth. So odontogenic infections are the most common cause of deep neck infections in adults. They present with facial pain and swelling. And usually the culprit is dental caries. When dental caries, the infection involves the pulp of the tooth, you get an apical or a periapical abscess at the tip of the root of the tooth, and this can break out and produce inflammatory changes. You can have phlegmon or abscess formation, which can be along the buccal or the lingual margins of the maxilla or mandible, in the sublingual space, or in the overlying facial soft tissues. The key to the diagnosis is the periapical lucency involving the root of the offending tooth. So this is a young patient who came into the ER with left jaw pain and swelling, and a CT neck with contrast was obtained. And at the level of the mandible, you can see considerable inflammatory changes in the left cheek. There's thickening of the platysma, reticulation of subcutaneous fat, and a rim-enhancing fluid collection marginating the buccal margin of the left mandibular body. The sagittal images showing the precise location of this abscess, and on the bone windows, that characteristic periapical lucency surrounding the root of a mandibular premolar, an odontogenic abscess arising from a carious mandibular premolar. If the infection involves a mandibular molar, it can spread to involve the submandibular and the masticator spaces. And this is because the roots of the mandibular molars extend below the mylohyoid muscle, which separates the sublingual and submandibular spaces. Once infection gains access to the masticator space, it can spread along the branches of V3 and through the foramen ovale into the intracranial compartment. This is a patient who had an extraction of a mandibular molar a week ago and presented with increasing cheek swelling and pain. And you can see this multilobulated rim-enhancing fluid collection consistent with an abscess centered along the mandibular ramus involving the masticator space. There is edema of the muscles of mastication, acute inflammatory changes in the subcutaneous fat. There is secondary edema within the left parotid gland. The coronals showing this very extensive abscess along the within the masticator space. It involved the temporomandibular joint, and you can appreciate how this can easily gain access through the foramen ovale into the intracranial compartment. The infection of maxillary teeth can also involve the masticator space, but can also involve the maxillary sinus, the palate, and overlying facial soft tissues. The next patient in the ER today is a 33-year-old with sore throat and complaining of increasing throat pain and odynophagia for 1 week. Again, a CT neck with contrast was seen, and at the level of the mandible, there is diffuse enlargement of the palatine tonsils, which approximate in the midline, the so-called kissing tonsils sign. And within the right palatine tonsil, you can appreciate this rim-enhancing fluid collection. It appears to be mildly septated, consistent with an abscess. Further down, an enlarged hyper-enhancing right level 2A lymph node. So this was acute tonsillitis complicated by a peritonsillar abscess. Now, tonsillitis is the most common deep neck infection in children and adolescents. It presents with sore throat, odynophagia, otalgia, and trismus. Infection can spread to the peritonsillar space, which is basically a potential space between the tonsillar capsule and the superior pharyngeal constrictor. And peritonsillar abscesses, they occur characteristically superolateral to the tonsil and usually have to be surgically drained. This is a case from the literature showing diffusely enlarged, enhancing palatine tonsil, again approximating in the midline, the tonsil sign, the characteristic striated pattern of enhancement, which is typical of acute pharyngotonsillitis. And further up, you can see rim-enhancing fluid collections consistent with abscesses within bilateral tonsillar fossa, and the coronals nicely showing that these abscesses are along the superolateral margin of the enlarged tonsil, typical of peritonsillar abscesses. Now, you can rarely have an intratonsillar or a tonsillar abscess, and these are much less common as compared to a peritonsillar abscess. And it's important to distinguish between the two because peritonsillar abscesses usually require surgical drainage, whereas intratonsillar abscesses may not. And they can often be treated just with IV antibiotics and supportive measures. So here is a patient who came in with sore throat, and you can see these rim-enhancing fluid collections within bilateral tonsillar fossa. And on the coronals, it was felt that these involved the entire meat of the palatine tonsil. And so these were intratonsillar abscesses, and this patient was successfully treated with IV antibiotics. Either way, infection can spread to adjacent parapharyngeal space, the masticator space, or the submandibular space. The next patient in the ER is a 69-year-old with history of sialadenitis and now presenting with increasing swelling, hoarseness of voice, and dysphagia. Axial CT neck with contrast at the level of the mandible. You can see diffusely enlarged hyper-enhancing left submandibular gland with ductal dilatation and multiple radiopaque calculi, consistent with sialadenitis with sialadenitis, the mild inflammatory changes surrounding it. And the submandibular duct, or the Wharton's duct, is diffusely dilated. There is a large calculus along its proximal aspect and a small one distally at its opening into the sublingual space. And so this was, acute sialadenitis in a patient with known sialadenitis. But on further attention, you can appreciate that there is edema within the floor of mouth, better seen on this lower image, diffuse edema within the sublingual space extending down into the submandibular space and the supraglottic soft tissues. And on the sagittals, this diffuse edema within the floor of mouth, pushing that tongue backward with narrowing of the oropharyngeal airway. So this was a patient with acute sialadenitis complicated by Ludwig angina. Now, Ludwig angina is a rapidly progressive, potentially life-threatening cellulitis of the floor of mouth involving the sublingual and submandibular spaces. The edema displaces the tongue posteriorly, causing airway compromise, and it's usually caused by an odontogenic infection arising from a mandibular tooth, but it can be due to any infection in the neck. And here is a case from the literature showing extensive inflammatory changes in the region, in the submandibular region, and you have diffusely enlarged edematous submandibular glands, multiloculated fluid collections in the floor of mouth, the tongue is displaced posteriorly, there is effacement of the oropharyngeal airway. Important to remember, Ludwig angina is a cellulitis. You do not need to have fluid collections or enhancement to, qualify to call it Ludwig angina. Always pay close attention to the airways, and I really like the sagittal reformatted images for that. The next patient in the ER is a 68-year-old with acute onset of neck swelling and difficulty breathing. On further questioning, the patient gave history of hypertension and is on lisinopril. CT neck with contrast at the level of the mandible showing diffuse enlargement and edema of the tongue, extending into the submandibular region, epiglottis, the supraglottic soft tissues, the sagittal reformatted images showing that diffusely enlarged tongue protruding out through the oral cavity. And this is a classic angioedema related to ACE inhibitor. Now, angioedema is a transient subcutaneous or submucosal swelling involving any loose connective tissue in the body. But it has a propensity for the face, tongue, lips, and larynx, and that's why we see it quite frequently on our CT necks from the ER. It can quickly cause airway compromise, so particular attention to the airways is warranted. And the classic culprit is ACE inhibitors, but it can be an allergic reaction to anything, or even IVTPA for patients who treated for stroke, especially in those who are also on ACE inhibitors. On imaging, you just see diffuse infiltrative transfacial edema. You may see mucosal thickening with no enhancement or hyper enhancement and airway compromise. This patient has diffuse swelling or edema of the lower lip. Angioedema due to an ACE inhibitor is a subacute kind of angioedema. It builds up over 1 to 2 days and usually resolves after you stop the drug within a couple of days and with supportive therapy. This is in contradistinction to the acute anaphylactic angioedema, which usually, that's a medical emergency requiring epinephrine, oxygen, fluids, etc. And then you have the acute allergic angioedema, which usually responds and is a little milder than the anaphylactic angioedema and will respond to antihistamines and corticosteroids. Moving on to the next location, the neck. And the next patient in the ER is a 68-year-old with 6 weeks of left jaw pain, worsening swelling for 2 weeks. Axial CT neck with contrast. At the level of the mandible, there is inflammatory changes overlying the left lower cheek. You can see reticulation of subcutaneous fat, thickening of the skin, enlarged edematous parotid gland. And within this, you see a large rim-enhancing fluid collection consistent with an abscess. The coronal reformats again showing those inflammatory changes, enlarged parotid. So this is acute parotitis complicated by an intraparotid abscess. Acute sialadenitis or inflammation of the salivary glands usually presents with salivary colic, which is pain and swelling of the salivary gland, which is worse with eating or even the thought of eating. And it's usually staph infection that causes it. And usually you'll have stones or sialoliths causing salivary duct obstruction, which predisposes to inflammation of the gland. But this could happen without any stones in patients who have dehydration or viral infections such as mumps. These predispose. 85% of stones are seen in the submandibular gland, and that is because the submandibular secretions are more viscous. They contain more oxalates and phosphates that tend to precipitate more than, say, parotid secretions. And also the submandibular duct has a more vertical course, which predisposes to stasis and obstruction. On imaging, you will see edema and enhancement of the gland. You may see ductal dilatation. You may see sialoliths. This is a patient who had left submandibular sialadenitis. You can see an enlarged hyperenhancing submandibular gland. There is stranding of fat surrounding it, consistent with inflammatory changes, thickening of the platysma, some reactive lymph nodes. And further down, you can appreciate the diffuse dilatation of the submandibular gland with a stone obstructing its distal orifice opening into the sublingual space. The next patient in the ER presents with sore throat and progressive odynophagia for 2 days. A CT neck with contrast obtained, and in the submandibular region, the arrows are pointing to diffuse edema of the epiglottis, the posterior pharyngeal wall, the ariepiglottic folds. There's really no enhancement, no fluid collection, and this patient has acute epiglottitis or supraglottitis, which is an inflammation of the epiglottis and adjacent supraglottic structures. Acute epiglottitis is usually the term reserved for inflammation of the epiglottis in children, which is usually due to the Haemophilus influenza infection, and it causes airway obstruction in children because they just have narrower airways. But the term in adults is actually acute supraglottitis, and in adults, it's becoming more common in adults, but it has a more indolent course. The airways are larger in adults, so it doesn't cause airway obstruction, and it may be even due to streptococcus. On imaging, you will see an edematous epiglottis. You may see a mucosal enhancement and fat stranding in the tongue base, supraglottic larynx. So here, that classic thumbprint sign on a lateral soft tissues neck radiograph in a child with acute epiglottitis. And there is this density represents an edematous aryepiglottic fold. This is an adult with acute supraglottitis and edematous epiglottis, which you can see on the sagittals, corresponds to this thumbprint on this lateral neck radiograph. And this is an edematous aryepiglottic fold, which corresponds to this triangular density. And there is also hyperenhancement of the lingual tonsils. So there are other causes for acute epiglottitis. It can be due to direct spread of edema from an adjacent infection, or even due to non-acute granulomatous conditions like sarcoidosis, GPA, or amyloidosis. The next patient in the ER is a 56-year-old with acute onset of neck pain, fever, odynophagia, and had an elevated white count and C-reactive proteins. CT neck with contrast obtained, and at the level of the mandible, you can appreciate there is retropharyngeal edema, no rim enhancement, somewhat hypoattenuating longus colli muscles. The sagittal reformats nicely outlining the retropharyngeal edema, which extends from the skull base to about C4, just in the upper cervical spine. And on the bone windows, you see this amorphous calcification along the anterior margin of the C1 arch, also nicely appreciated on the sagittal reformats. And this is classic acute longus, calcific longus colli tendinitis. This is a self-limited disease due to deposition of hydroxyapatite crystals in the longus colli tendon. It responds well to non-steroidal anti-inflammatory drugs, and it clinically mimics a retropharyngeal abscess. So it's important to do that CT and demonstrate no rim enhancement in that retropharyngeal effusion or edema, which is just reactive. The key to making this diagnosis is that small calcification or ossification anterior to the C1 arch along the longus colli tendon. And you may see edema in the longus colli muscles. This is an MR, sagittal and axial, stir sequences. You can see this retropharyngeal edema in the upper cervical spine, and the T2 hypointense signal corresponding to the calcification, which is of course better seen on CT. The next patient in the ER is a 3-year-old with increasing pain, drooling, and odynophagia following an upper respiratory tract infection. A CT neck with contrast was obtained and demonstrated a multi-septated, large, rim-enhancing fluid collection within the retropharyngeal space, asymmetric to the left with extensive surrounding inflammatory changes, mass effect on the oropharyngeal airway. The sagittal reformats showing the extensive septocaudal extent of this retropharyngeal abscess. So retropharyngeal abscess is basically extranodal purulent fluid collection in the retropharyngeal space. And it may be due to suppuration of retropharyngeal lymph nodes from tonsillitis, pharyngitis, or dental infections. It can also be due to direct spread from discitis osteomyelitis, or it can be due to penetrating trauma with inoculation of the retropharyngeal space by bacteria, such as the infamous popsicle stick accident. CT localizes the infection and distinguishes between edema and abscess. A rim-enhancing, hypoattenuating fluid collection expanding the retropharyngeal space with a convex anterior margin is classic of an abscess, and it may contain air. The potential complications are serious. Descending mediastinitis can occur due to spread of infection through either the danger space, the visceral space, or the carotid sheaths. You may have airway compromise, and there could be vascular complications, which include jugular vein thrombosis or carotid pseudoaneurysms. It's a good time to review the anatomy of the retropharyngeal space and the danger space. So the retropharyngeal space is, as the name implies, posterior to the pharynx, and it is this space outlined in yellow. It is bound anteriorly by the buccopharyngeal fascia and posteriorly by the alar fascia. It is anteromedial to the carotid space, posteromedial to the parapharyngeal space. The danger space is posterior to the retropharyngeal space. So the yellow outlines the retropharyngeal space, and the red is the danger space, and the white is the prevertebral space. So the retropharyngeal space is marginated by the buccopharyngeal fascia anteriorly, alar fascia posteriorly. The danger space is marginated by the alar fascia anteriorly and the prevertebral fascia posteriorly. What's important is that the buccopharyngeal fascia and the alar fascia fuse usually at the cervicothoracic junction, but anywhere from C6 to T4, and that marks the end of the retropharyngeal space. But note that the danger space extends from the skull base all the way down to the diaphragm, and so it contains loose areolar tissue, which allows easy pathway for spread of infections. And so an infection that seeds the danger space can go all the way down into the mediastinum. Important to note that the retropharyngeal space and the danger space are indistinguishable in a healthy patient. The danger space will become visible only when it is distended by fluid or pus below the level where the retropharyngeal space ends, which is usually T1 to T6. This is a nice example from the literature of a retropharyngeal abscess, which was complicated by descending mediastinitis. You can see air and fluid within the retropharyngeal space, consistent with infection in the retropharyngeal space. But further down in the upper thoracic region, there is fluid this is the danger space, and this is descending mediastinitis from the spread of infection. Another case of descending mediastinitis, the air and fluid within the retropharyngeal space up above, but always remember to look down into the mediastinum, and here you have air and fluid within the mediastinum posterior to the esophagus and trachea, and that's descending mediastinitis. This is a serious complication which often has a very subtle non-specific signs and symptoms, and you as a radiologist could be the first to suggest this complication. Discitis osteomyelitis, this is a hematogenous, it could be due to hematogenous seeding or recent spinal procedure, or it could be spread of adjacent infection, and this could be a cause of retropharyngeal abscess. The risk factors include IV drug abuse, infective endocarditis, diabetics, patients on steroids or immunosuppressants. On imaging, you will, and it's better evaluated obviously on MRI. On imaging, you will see a decrease in the disc height, which may contain edema or enhancement. You'll have cortical irregularity of the end plates with a progressive vertebral body collapse. This patient, this is a sagittal stir sequence. There's marrow edema in the adjacent vertebral bodies. On the post-contrast, you can see that enhancement. And there is an extensive retropharyngeal or prevertebral phlegmon, no fluid collection, and also an epidural phlegmon, which are all complications, and this is causing canal stenosis and cord compromise. Septic facet arthritis is an uncommon but a serious condition that can present with neck pain and bring the patient into the ER. So one should always be aware to look at the cervical spine on the CT next that we do. It's usually a single level facet joint infection, and of course MRI is more sensitive. On imaging, this is a sagittal stir and post-contrast T1 weighted images. You can see fluid distending the involved facet joints, extensive edema and inflammatory changes in the adjacent paravertebral soft tissues. On the post-contrast imaging, you can see rim-enhancing multilobulated fluid collection consistent with an abscess and extensive phlegmon. This infection can seed the spinal canal and can result in meningitis, epidural extension with phlegmon or abscess formation, cord compression. So important to look at, try to look at soft tissue detail and get an MR when suspected. Another condition that you must be aware of that can present in the emergency room is Lemierre syndrome. Now, this is a post-pharyngitis venous thrombosis. It's a suppurative thrombophlebitis in the neck. It's caused by an opportunistic infection by an anaerobic bacteria, which is a commensal in the oropharyngeal flora, a Fusobacterium necrophorum. This causes septic thrombophlebitis and septic pulmonary emboli. More than 90% occur after a pharyngitis, but it can be due to any infection, a sinus, dental, or ear infection. And it usually is seen in healthy, immunocompetent teenagers or young adults who will give you a history of preceding pharyngotonsillitis, which could be quite minor. They might just have a flu-like illness a week prior to their presentation. Important to recognize, it has a 4 to 12% mortality despite aggressive treatment. So you as a radiologist may be the first to suggest this diagnosis. The classic imaging triad of Lemierre syndrome is pharyngitis, neck vein thrombosis, and cavitary pulmonary nodules that represent the septic pulmonary emboli. In this case, from the literature, at the level of the oropharynx, you can see diffuse edema and enlargement of the left palatine tonsil, edema extending into the adjacent neck spaces. So this patient has acute pharyngotonsillitis. There is a filling defect within the internal jugular vein consistent with thrombophlebitis. And here there is a nodule in the left lung, which is the pulmonary embolus. So look for the neck inflammatory changes, the reactive lymphadenopathy. You could have reactive retropharyngeal effusions. Always try to tie it all in. Even if you're not seeing any inflammatory changes, but a young, otherwise healthy a young adult comes to the ER and you're seeing a jugular vein thrombosis and a non-specific lung opacity, think of Lemierre's. Carotidynia can also present as an emergency. This is correctly termed typic syndrome, transient perivascular inflammation of the carotid artery. This is a self-limited inflammatory disorder presenting with neck tenderness and increased pulsations overlying the carotid bifurcation. You will see circumferential carotid wall thickening involving the distal common carotid artery or the carotid bifurcation or the proximal ICA with little to no luminal narrowing. And MRI can pick up intense enhancement of the vessel wall. So here in this patient, you can see this perivascular infiltration around the carotid artery. Note the nice crisp fat planes along the right side. And there is a little bit of vessel wall enhancement that you can pick up, which would be much better appreciated on an MRI. This is a diagnosis of exclusion. If you have said this could be carotidynia, it should be followed up after resolution. After 2 weeks, the patient should be re-imaged to make sure that there is an alternate process going on. Moving on to sinonasal tract emergencies, which basically involve complications of acute rhinosinusitis, invasive fungal sinusitis, and some benign tumors that may present to the ER. So the next patient in the ER is a 23-year-old with history of chronic sinusitis, presenting with new onset of facial and eye swelling and headache. CT neck with contrast was obtained, showing diffuse opacification of the frontal sinus. There are marked inflammatory changes in the overlying soft tissues with enhancement. There is a rim-enhancing fluid collection marginating the frontal sinus, consistent with a subgaleal abscess. And also, there was edema in the left frontal lobe, very concerning for intracranial spread. So an MRI was obtained, and you can see a rim-enhancing fluid collection in the left frontal lobe with diffusion restriction consistent with an intraparenchymal abscess, dural thickening, some meningeal enhancement, and consistent with meningitis. And note the diffusion restriction throughout the frontal sinus and in that subgaleal abscess consistent with pus. So this was a pot-puffy tumor or subgaleal abscess related to the frontal sinus. It is basically a frontal bone osteomyelitis that complicates chronic frontal sinusitis, and you will see A rim-enhancing fluid collection in the soft tissues of the forehead overlying the frontal sinus. You may see focal bone lysis, sequestrum formation, or reactive sclerosis, and it's usually due to a staph or strep infection, but could be Haemophilus or Klebsiella. Intracranial complications of sinusitis are not uncommon and can involve the extraaxial and intraaxial spaces. You could have meningitis, cerebritis progressing to abscess formation. Cerebritis, you will see ill-defined edema in the brain as long TR hyperintensity with ill-defined enhancement. As it progresses to an abscess, you'll see rim-enhancing fluid collection with surrounding edema, diffusion restriction. If you have enhancement of the meninges, it implies meningitis, which could be localized or diffuse. Here in this patient, you can see a diffuse edema in the left frontal lobe, which didn't really show any rim-enhancing fluid collection consistent with cerebritis, but there was a meningitis, meningeal dural thickening and enhancement, and a developing subgaleal abscess. Infection in the extraaxial space can result in subdural empyemas or epidural abscesses. So you'll see extraaxial fluid collection along the adjacent sinus. You may not see bony dehiscence or erosion because infection can spread from the sinuses into the intracranial compartment through valvulus veins. Excuse me. And so here in this patient who has extensive sinus mucosal disease, there is a subdural rim-enhancing fluid collection consistent with a subdural empyema and leptomeningeal enhancement consistent with a localized meningitis. In a different patient, there is a subdural empyema along the left side of the forks, and the culprit was a sphenoid sinusitis. Cavernous sinus thrombosis is a dreaded complication of sinusitis and can bring the patient to the ER. You will see heterogeneous or decreased enhancement within an enlarged cavernous sinus, which may show a convex lateral margin. You may have enlargement or thrombosis of the superior ophthalmic vein with absent flow void. You will often see intraorbital venous congestion with stranding of the retrobulbar fat. The cavernous ICA may be narrowed. This was a patient who had sinusitis and came in with bilateral proptosis and eye pain. And you can see this very heterogeneous enhancement within bilateral cavernous sinuses. They look enlarged. They have slightly convex lateral margins. There is bilateral proptosis, little infiltration and enhancement of the retrobulbar fat that is seen on the right side. And on an image above, you see filling defects within bilateral superior ophthalmic veins that are seen on the coronals, consistent with bilateral cavernous sinus thrombosis and superior ophthalmic vein thrombosis. The next patient in the ER has B-cell lymphoma and is status post a stem cell transplant and now is presenting with headache. CT of the neck was obtained, which showed diffuse opacification of the left maxillary sinus, chronic osteitis, sclerosis of the walls consistent with a chronic left maxillary sinusitis. But there was infiltration of the preantral fat and the retroantral fat, which were very concerning findings. An MRI was obtained and the pre and post contrast T1 weighted images confirming that infiltration, there's enhancement within the preantral fat and the retroantral fat. Within the left maxillary sinus, there was this large area of non-enhancement or loss of contrast enhancement. And importantly, the arrow is pointing to a non-enhancing mucosa of the maxillary sinus, which is very suggestive of invasive fungal sinusitis with necrotic tissue. So acute invasive fungal sinusitis is a rapidly progressive transmucosal fungal sinus infection, usually seen in immunocompromised patients, patients with neutropenia, hematological malignancies, uncontrolled diabetes, immunosuppressive therapy or chemotherapy, and the usual culprits are Aspergillus or Mucor, which are invasive fungi. The patient presents with fever, facial pain, sensation loss, vision changes, altered mental status, and the infection can spread from sinuses via vascular invasion, causing bone erosion and both intracranial and intraorbital spread, and cavernous sinus invasion. Despite early treatment with antifungals and surgical debridement, the mortality remains extremely high at 50 to 60%. So the imaging findings will include sinus opacification with stranding in the periantral fat. It could be in the pterygopalatine fossa, in the orbit, along the nasolacrimal duct, the lacrimal sac. Basically, soft tissue where it should not be is a red flag. You may see bone erosion, dehiscence, nasal septal ulceration. In this coronal CT, you can see diffuse mucosal thickening and extensive opacification of the right mastoid air cells, bony erosion along the lamina propria and septi of the ethmoid sinus, extensive soft tissue infiltration of the adjacent orbit. On an contrast-enhanced CT or an MRI, better an MRI, you will see non-enhancing sinonasal mucosa or something called loss of contrast enhancement, the LOCE lesion, which suggests necrotic tissue. On this patient with an MR, you can see the diffuse enhancement of the sinusitis within the ethmoid sinuses, diffuse infiltrative enhancement within the orbit, also extending into the periorbital region, some marrow infiltration here along the sphenoid wing, and importantly, on the coronals, note the normal left side, there is diffuse enhancement, normal enhancement of the middle and the inferior turbinate, but on the right side, there is loss of enhancement within the middle and the inferior turbinate, and this is the black turbinate sign indicating necrotic tissue and a very characteristic finding of invasive fungal sinusitis. You can have intracranial spread with meningitis, phlegmon, abscess. You can have intraorbital spread with post-septal cellulitis, subperiosteal abscess formation. Vascular invasion can result in cavernous sinus thrombosis or even arterial involvement with narrowing, dissection, or pseudoaneurysms. Important point is that the degree of sinonasal mucosal thickening or opacification may be minimal, and it does not predict the presence or absence of invasive fungal sinusitis. Always look for that soft tissue where it does not belong. These are two different patients with cavernous sinus thrombosis due to invasive fungal sinusitis, showing, in addition to the heterogeneous enhancement within an enlarged cavernous sinus, loss of flow void within the left carotid artery, consistent with occlusion. Same thing, but on the opposite side in another patient, loss of the flow void, note the normal side. The next case in the ER is an 11-year-old boy presenting with severe epistaxis. A CT neck with contrast shows an avidly enhancing multilobulated mass within the posterior right nasal cavity. It's extending into the right sphenoid sinus. It's enlarging the sphenopalatine foramen and the pterygopalatine fossa. These arrows are pointing at what a normal sphenopalatine foramen and pterygopalatine fossa should look like. It should contain fat. The sphenopalatine foramen is located along the lateral wall of the superior meatus, and it is the opening of the pterygopalatine fossa into the nasal cavity. So this is a classic juvenile nasopharyngeal angiofibroma, or JNA. This is a benign, vascular, locally invasive mass centered in the posterior nasal cavity, which is seen almost exclusively in young male adults, 8 to 25 years of age, and presents often with profuse epistaxis in the ER, but they can be unilateral nasal obstruction. Some patients may have chronic otomastoiditis due to obstruction of the eustachian tube, and it arises in the sphenopalatine foramen. So this is the classic origin of the tumor, from where it extends into the nasal cavity, into the nasopharynx, into the pterygopalatine fossa, masticator space. It can, once it gains access to the masticator space, it can extend up into the intracranial compartment, into the orbit. And these are usually surgically resected, but because they are so vascular, the surgeons will often request the interventional radiologist to preoperatively embolize these before they go into to resect it. On MR, they are avidly enhancing heterogeneous diffuse masses within the nasal cavity in the region of the sphenopalatine foramen. And here you will often see these, this is an axial stir showing these serpiginous flow voids within the mass, which implies the highly vascular nature of this mass. It can extend out into the masticator space, into the nasopharynx, and characteristically produces this bony remodeling that produces anterior bowing of the posterior wall of the maxillary sinus. Post contrast showing avid enhancement, again, those tubular flow voids. And this bony remodeling, it can be destruction also, but I'm going to go back to the previous slide. This bony remodeling with anterior displacement of the posterior wall of the maxillary sinus is quite characteristic of GNAs. On angiography, you will see an intense tumor blush with enlarged feeding arteries and usually supplied by the internal maxillary branch of the external carotid artery. Moving on to the orbits. In the orbits, the infection can be limited to the preseptal space, which is called preseptal cellulitis. The infection is limited to the skin and soft tissues anterior to the orbital septum. Now, the orbital septum is a thin fibrous sheet extending from the orbital rim, periosteum, to the tarsal plates. And this serves as a barrier for spread of infection from the soft tissues into the orbit. And it can be due to contiguous spread of infection from the sinuses. That's the most common cause. But infection from the teeth, ocular adnexa, insect bites, trauma, all of them could produce preseptal cellulitis. On CT, you'll see this characteristic increased density and enhancement in the periorbital soft tissues and in the eyelids. The next patient in the ER is a 23-year-old with chronic sinusitis presenting with increasing proptosis and eye pain. And on the CT neck with contrast, you can see marked proptosis of the left eye. There is a multilobulated rim-enhancing fluid collection within the medial extracorneal space extending out into the preseptal soft tissues, displacing that globe anteriorly. An MR was obtained which confirmed this multilobulated subperiosteal abscess with diffusion restriction consistent with pus. So orbital cellulitis or post-septal cellulitis is infection posterior to the orbital septum. It can involve the extracorneal or intracorneal spaces. You can get a phlegmon, you can get an abscess. If it's a phlegmon, you'll just see an enhancing infiltrate without a discrete abscess. Complications include subperiosteal abscess, optic neuritis or perineuritis, dacroadenitis, intracranial spread can happen, cavernous sinus thrombosis can happen. So this is an emergency. And sinusitis is the most common cause, but of course other causes include trauma, foreign bodies, sepsis, fungal infection, and immunocompromised. And the patient will have proptosis, fever, chemosis. If they have loss of vision or loss of eye movement, that's usually an ominous sign. The next patient in the ER is a 20-year-old who had an endoscopic sinus surgery a week ago and now is presenting with increasing facial pain, facial swelling and eye pain. And on the multiple images from a CT neck with contrast, there is extensive fluid and within multiple paranasal sinuses likely related to the endoscopic sinus surgery. There was preseptal cellulitis. Here you can see diffuse infiltration of the fat along the lower eyelids. And within the left orbit, there is this lenticular enhancing soft tissue along the medial extracorneal space consistent with a subperiosteal phlegmon likely. And further down, there was diffuse soft tissue thickening along the medial canthus, and on the coronals, you can see these tiny rim-enhancing fluid collections within this enhancing soft tissue consistent with bilateral dacryocystitis. So orbital cellulitis on MR, it's better evaluated, and you will see infiltrative, ill-defined intraorbital enhancement, as you can see over here with proptosis. If you have tenting of the globe, it implies nerve traction and as an emergency. MR is better for the complications, and those could include superior ophthalmic vein thrombosis, cavernous sinus thrombosis, intraorbital spread. If you have a restricted diffusion, it implies abscess formation. You can evaluate for optic neuritis or perineuritis, dacroadenitis. This patient had filling defects within bilateral superior ophthalmic veins, so orbital cellulitis complicated by superior ophthalmic vein thrombosis bilaterally. The next patient in the ER is a 3-year-old with periorbital swelling and fever. And the CT neck with contrast shows diffuse opacification of the paranasal sinuses consistent with sinusitis. There was dehiscence along the lamina pepritia, better appreciated on the coronals, with this rim-enhancing fluid collection, lenticular in shape within the medial extracornal space, extensive inflammatory changes, and this is a subperiosteal abscess complicating acute sinusitis. So subperiosteal abscess is a collection of pus between the orbital wall and the orbital periosteum due to an adjacent infection. You will see a lenticular rim-enhancing fluid collection, usually medial along the medial wall of the orbit or superior wall of the orbit. And there is displacement or enlargement of the medial and superior rectus muscles and usually associated sinus disease. Look out for those complications, periorbital cellulitis and thrombosis of the superior ophthalmic veins or cavernous sinus. The next patient was a 25-year-old with chronic sinusitis and came in with increasing eye pain and headache. An MR was obtained, and the coronal stir sequence shows you diffuse opacification or sinus mucosal disease. There is diffuse infiltration of retrobulbar fat, more on the left than the right side. The post-contrast imaging showing that diffuse enhancing infiltrative soft tissue within both orbits, consistent with orbital cellulitis. There is a rim-enhancing fluid collection along the roof of the orbit consistent with a subperiosteal abscess, and further anteriorly, a rim-enhancing extraaxial fluid collection in the intracranial compartment. This is an epidural abscess. Moving on to dacry cystitis, which can present in the ER. It is an acute infection of the nasolacrimal system and usually predisposed to by either congenital or acquired stenosis or obstruction of the nasolacrimal duct. The patient will present with acute onset of pain, erythema, and tenderness over the lacrimal sac and the medial canthus, and there may be purulent discharge. On CT, you will see a rim-enhancing fluid collection at the medial canthus where the lacrimal sac resides, with surrounding inflammatory changes and soft tissue thickening. Moving on to the ears, we're going to start with necrotizing external otitis or malignant otitis externa. This is a severe invasive infection of the external auditory canal, adjacent soft tissues, and the skull base caused by Pseudomonas. It is also called skull base osteomyelitis as it can spread from the external auditory canal to the middle ear, petrous apex, temporomandibular joint, and adjacent spaces including masticator space, carotid space, nasopharynx. It's all usually seen in diabetic patients, immunocompromised, and HIV patients, and who present with severe otalgia and otorrhea. If there is cranial nerve palsies, it heralds skull base osteomyelitis. This is a nice case from the literature showing diffuse opacification of the right external auditory canal. Note the nice normal side on the left, the nice very preserved bony anterior wall of the external auditory canal, which is completely eroded on this side, with an additional erosion along the anterior wall of the glenoid fossa. So this is classic necrotizing external otitis. MR is superior to evaluate for the extent of the disease. You will see soft tissue thickening of the EAC. You may see abnormal enhancement, cortical bone erosion, infiltration of fat planes beyond the EAC. It can result in phlegmon or abscess formation. If the marrow is involved, you will see marrow edema and enhancement with loss of the fatty marrow signal and also any intracranial complications. So here in this pre and post contrast T1 images of an MRI, you can see that this diffuse opacification and enhancement along the external auditory canal with diffusely infiltrative soft tissue extending anteromedially, surrounding the carotid space, involving the right side of the clivus, extending into the nasopharynx, masticator space, a very extensive process. Otomastoiditis can get complicated and present in the ER. Intramastoid empyemas can happen with or without osteomyelitis. On CT, look out for erosion of the mastoid cortex or trabeculae, or something called coalescent mastoiditis, as you can see in this patient, where you have this coalescence of mastoid air cells and bony erosion along the medial margin. If there is erosion along the lateral margin, it can result in subperiosteal abscesses, which can be either periauricular or a bezold abscess. Now, the periauricular abscesses are the caused due to erosion along the lateral margin of the mastoid, and this is a classic periauricular or parauricular abscess along the lateral margin of the mastoid. Also note the epidural abscess complicating this mastoiditis. A bezold abscess is an abscess within the sternocleidomastoid muscle, so more inferiorly, and it's usually due to an erosion along the mastoid tip. You can have intracranial complications. This is a patient showing a cerebellar abscess with surrounding edema, meningeal enhancement consistent with meningitis, filling defect within the right sigmoid sinus consistent with dural venous sinus thrombosis. And lastly, vascular lesions can bring the patients to the ER. Venous thrombosis is not uncommon. You may see it in the hypercoagulable patients. This was a patient with colon cancer who presented to the ER with right neck pain. And you can see that there is a filling defect completely occluding the right internal jugular vein along its entire length. So right internal jugular vein thrombosis. If you see this in an otherwise healthy young patient, think of Lemierre's. Carotid blowout syndrome, a serious rupture of the carotid arteries and its branches, typically due to a pseudoaneurysm. Rupture as a complication, usually of radiation treatment for head and neck cancer, can result in severe neck hemorrhage. This was a patient who had had prior radiation therapy to the neck, presented with right-sided neck swelling and pain. And the CTA showed this large pseudoaneurysm arising from the internal carotid artery. So, with a large non-enhancing soft tissue thickening consistent with a hematoma, and this is an impending carotid blowout with hematoma. So that brings us to the end of today's talk, and there are certain pearls or takeaway points. Always assess airway patency and be alert for potential airway compromise, particularly if edema involves the sublingual space. Be alert to intracranial spread of infection, especially if the masticator space is involved, as infection can spread intracranially via the foramina valley along the three branches. Always evaluate for internal jugular vein thrombosis in the neck and dural venous sinus thrombosis if intracranial spread is present. Remember to think of Lemierre syndrome in case of unexplained internal jugular vein thrombosis in an otherwise healthy young adult. The retropharyngeal space extends from the skull base to the thoracocervical junction, but the danger space extends from the skull base to the diaphragm. So always look down into the mediastinum anytime you see an infection involving the retropharyngeal space to pick up on descending mediastinitis. And in cases of invasive fungal sinusitis, remember that the degree of sinus mucosal thickening, it does not correspond or does not predict the presence or absence of invasive fungal sinusitis. It may be minimal. Always look for soft tissue where it should not be, especially in at-risk patients. Thank you, and I'll be happy to take any questions.
Thank you, ma'am, for that amazing session. And I think we could write a textbook chapter on this. You have all the pathologies that can come across in an ER shift. So everyone loved it, and we're getting lovely encouraging comments in the chat box as well. There are a few questions in the Q&A. Can I just put them across one by one?
Yes, please.
Yes, ma'am. You can also go through them as I read along in the Q&A box. The first question is phlegmon the same as fluid collection, and do we use this term?
Okay, that's a good question. A phlegmon is not the same as a fluid collection. When I see just enhancing soft tissue, ill-defined soft tissue, that is the stage of a phlegmon. When a fluid collection forms with a rim enhancement, it has progressed to an abscess. Of course, if you have a fluid collection without rim enhancement, it could be just a reactive effusion.
The next question is, why do we use the term preseptal when it's not visible on imaging? Rather, can we use the terms like preorbital or postorbital?
So it is definitely visible on imaging. The preseptal implies that it is not intraorbital, and you definitely see stranding of fat and soft tissue thickening along the eyelids and in the anterior to the orbit. So it is not that it's not seen on imaging. And of course, preseptal versus then intraorbital implies a way more serious infection when you're talking post-septal or intraorbital. Pre-septal cellulitis or infections are treated conservatively.
Okay, thank you, ma'am. Regarding the thrombus in the vascular channels, there are two questions. How to differentiate a filling defect in IJV, like a thrombus versus thrombophlebitis?
So, thrombophlebitis, you will have inflammatory changes or stranding of fat surrounding the internal jugular vein, and inevitably there will be a filling defect within that internal jugular vein. It may not be occlusive, but it usually results, a thrombophlebitis will result in a thrombus which may not be occlusive. So I do qualify in the report that I have occlusive or non-occlusive venous thrombosis.
The next question is, for cavernous sinus thrombosis, is there any particular phase of contrast that needs to be obtained? Like, what's the delay after the contrast injection?
So, frankly, I find that the best sequence to evaluate for cavernous sinus thrombosis, believe it or not, is an MRA, time of flight MRA of the head, which shows arterialized flow within the superior ophthalmic veins. And that's just like, it's always shows up. But if you, it is often, of course, we do post-contrast imaging in most of these patients. And it's best seen if you do fat suppression on your, post-contrast, but even the 3D SPGRs post-contrast show it up very nicely. You just want like thinner cuts through the cavernous sinuses.
Yeah, thank you, ma'am. You mentioned about the phlegmon and fluid collection and how to differentiate that, like a phlegmon from an abscess.
Yeah. So a phlegmon from an abscess, when you don't see a well-defined rim-enhancing fluid collection, it is in the phlegmonous stage. Once you see a rim-enhancing fluid collection, it has progressed to an abscess.
Thank you, ma'am. The next question from Shebin is how to differentiate between invasive fungal sinusitis and neoplasm.
That's a good question. Usually in, the history, a neoplasm does not produce the kind of inflammatory or infiltrative soft tissue that you will see in cases of invasive fungal sinusitis. And the history is very characteristic. It's usually an immunosuppressed or a diabetic patient coming in with a sinus infection. That's usually the history I get. And then I look for soft tissue where it shouldn't be, which usually is not as mass-like as a neoplasm. It's infiltrative soft tissue, not mass-like soft tissue. And yeah, again, the history is key to the diagnosis.
I think the last question. There are a couple of more. Can we see a retropharyngeal edema in benign conditions or like an incidental finding?
You can see retropharyngeal edema as just a reactive to a bunch of surrounding things. Any infection in the neck can give you a reactive retropharyngeal edema. You can have reactive retropharyngeal edema with an osteodiscitis, you can have, so absolutely it can be there just as a reactive effusion. So it's important to look for rim enhancement because you do not want to drain a retropharyngeal reactive effusion. Only a retropharyngeal abscess needs to be drained.
Vrinda is asking about Ludwig's angina. What are the identification points?
So I look for Ludwig basically on all bad infective processes infecting the pharynx or the oral cavity. So if I'm seeing a bad odontogenic abscess or I'm seeing severe tonsillitis, I will always look for that cellulitis in the floor of mouth or in the submandibular region, and on the sagittals look for airway compromise, because remember, Ludwig angina is just severe cellulitis complicating an infection in the it implies potential airway compromise. So look for it on any infection that is severe enough that is producing edema.
Is the black turbinate sign helpful to differentiate from, like, how do we differentiate it from pathological fungal one and a normal one? Do we see a black turbinate sign in non-fungal cases or only in fungal cases?
It's pretty much only in fungal cases, and it basically implies necrotic tissue. And so, it's pretty specific for in conjunction with other findings for an invasive fungal sinusitis. And the black turbinate sign on clinical exam, the ENT people know that there is necrotic turbinate there. They can see it. It literally looks black even when you look in.
Okay, ma'am, thank you so much. That was, there's just one more question that's popped up. How to differentiate mucor versus other fungal sinusitis? Does it actually matter?
No, it doesn't matter, and you cannot differentiate it on imaging.
Yes, ma'am. Thank you so much for patiently answering. We had a wonderful session. It was worth our Sunday evening, hands down, and I'm sure you. Thank you again for spending your time on this Sunday morning for us. We hope to have you again on this platform with another topic, and you make them as interesting as they can get. It was lovely to have you, and
Thank you.
a pleasure. You can just go through the comments; they are really nice and encouraging in the chat box also.
Okay, thank you.
Thank you, ma'am.